Welcome to the Health Deli, your local stop for a fresh take on community health topics. Come on in, grab a number, and let the guys behind the counter, Mark, Ben, and Mike, tell you about today's specials.
Good day. Welcome to the deli, everyone. It is a beautiful day here in the Health Deli studios on the campus of Ferris State University in the television and digital media production building. Ben, how are you doing?
I'm doing pretty good. You know, it's hasn't snowed a lot up here yet. That's the big thing I'm worried about is when that starts happening again. So I'm doing okay.
All right. Mm-hmm. And Andrew, we gave you a microphone now.
I'm back. Hello,
okay,
everybody.
take the microphone away.
All right, cut.
Oh my goodness. Well, you know, we're missing Mark again. So it's always sad when the three of us aren't together. Sorry, four. I got to keep including a beverage boy over there. Yeah. But what's going on in the world, man? What do you got coming for us?
Yeah, for sure. So I teased this a little bit in the last episode, but I am putting together an episode about essentially those new weight loss drugs that have been coming out that have been in the news. So do they actually work? Are there any side effects with them? How should we use them? So it should be pretty cool seeing that this is kind of a brand new thing, right? To hopefully combat the obesity epidemic that we've been talking about for decades.
Yeah, and I just heard a bunch of stuff on the news about, some of those and some of the safety concerns and a variety of other things. So that's a really timely topic. That'd be great.
Yeah, for sure. It should be super interesting. I'm really excited for it.
Okay.
Yeah.
Well, for me, I'm working on a couple of things here as well. I want to look at the impact of good health at reducing outpatient antibiotic use. And I want to kind of build upon the series that we've had in seasons 1 and 2, where we go out and ask questions of, we've done kids and we've done college students. I'd like to take this to the other extreme now and go grandparents or those that are maybe at the other end of the age spectrum.
Okay. So questions from grandpa or grandma.
Yeah. Why do you keep looking at me?
You're projecting right now, Mike.
Yeah. Am I? All right. Well, let's just move right on to the topic of the day before this gets, too mean to me. I'm going to talk about vertigo.
Vertigo?
Yeah. And, to be honest with you, this was a term everybody knows, they've heard vertigo and stuff like that, but it's not something that I knew much about until about 6 years ago when I actually experienced an episode of vertigo.
Okay. And so vertigo, it's kind of just like dizziness, right? Or is there more to it?
Well, that's part of it.
Okay.
And so there's definitely a difference between dizziness and lightheadedness. And we'll talk about, that difference and stuff. But what I wanted to do first is, let people, understand kind of like what happened to me. Yeah. And so one day I was getting ready for some people to come over and I was starting to feel different. And I thought it was just, maybe I'm getting a little hungry. So I started to snack on a lot of foods. And the next thing I remember is all of a sudden the room started to spin and move. And I just was standing there thinking, oh my gosh, I'm going to fall. And, I hurried and ran to the bathroom and got there. And unfortunately, I spent a lot of time in the bathroom that day because associated with my vertigo was some nausea and vomiting.
Oh, okay.
And I don't know how long I laid there in the bathroom, but my wife eventually found me in the bathroom. And I was able to quit vomiting for a long enough period of time, and they were able to get me to the emergency department. I'm not sure what they gave me at that point in time, but I ended up in the hospital for a number of days.
Wow. So you were really out of it then when that was happening.
Yeah. I mean, so this was, definitely more than just your episode of dizziness or lightheadedness. And at that point in time, I was diagnosed with vertigo.
Okay.
But, to be clear, vertigo is actually not a disease. Vertigo is a symptom.
Okay.
And, like you mentioned, vertigo is just more than dizziness. It's the sensation that the environment around you is moving or spinning. And along with vertigo, you can experience, loss of balance, the dizziness, and unfortunately, nausea and vomiting.
Yeah.
And vertigo and dizziness, typically we don't think about it as being that bad. It's just, that person's got lightheaded and they just go lay down. But really, vertigo and dizziness are some of the most common reasons for medical visits, and they account for about 2 to 3% of all consultations in emergency departments. So not just doctors' offices, but the acute episodes are bad enough where people end up in the emergency department.
Okay, so it's so bad that people are like, I need to be hospitalized, essentially, right? Like,
I need help now.
Right, fair.
And because, as I learned, vertigo is one of the most debilitating conditions there is. Because just imagine sitting there and all of a sudden you feel like your room is spinning. You can't do anything. You just need to fall down. You can't move. You can't communicate. It's actually a pretty scary feeling.
Yeah, and I can only imagine if you don't feel like you can communicate or like call out to people, like how is anyone going to know that you're having that experience, right?
Well, and we'll talk a little bit more through my experience. We had to sit down and have a talk with my oldest daughter, so she would be able to know what to expect if she found me like that, how to communicate with 911 and stuff like that. Because, spoiler, I had an even worse episode about a month and a half ago where I was pretty much incoherent and couldn't even communicate. All I could say was hospital ambulance, and that's all I could get out.
Wow, that sounds really scary. And interestingly, you also mentioned that you kind of had this feeling before it happened that you're like, something's not right.
Well, sometimes that stuff happens and sometimes it doesn't.
Okay.
And that's one of the scary things about vertigo is we really cannot predict when it's going to happen. I've had episodes where I'm sitting at the computer feeling perfectly normal, and then the next thing I know, my room is spinning. And so it just comes on that quickly. Now,
Gotcha.
And before I just make this all about me, which is going to be a lot about me. By the way, this is the Klipser health topic of the season. We moved on from
prostate health,
my prostates, onto vertigo. But it's estimated that the lifetime prevalence for individuals who experience vertigo is between 20 and 30%. And vertigo occurs more commonly in females than males, and probably about a 1 to 2.5 ratio.
Okay.
And vertigo is also 3 times more frequent in elderly compared to younger individuals. So there are some obvious risk factors then, or some predispositions to having vertigo. Okay. And vertigo itself, those symptoms, they can last for seconds and be relatively mild, or they can last for hours. And I've had them where they've lasted for 12 hours and more, episodes of vertigo.
Okay. And so you said before that vertigo is more of a symptom than like an actual diagnosis. And so I guess what are the different things that can cause vertigo, and does that determine how severe it is? Like maybe some things cause a more mild vertigo versus others more severe?
Yeah. Let's talk about that. But before we do, let's talk a little bit more about the anatomy in your vestibular system. And the vestibular system itself is made up of 3 semicircular or half-circle hollow tubes or canals in the inner ear. And these semicircles detect motions of angles and accelerations. So these are located in 3 planes. So it tells you if you start to move in one direction or turn and go another direction. And this semicircular organ in your body is called the vestibular labyrinth.
Fancy. So you said it's in your ear. I know that most of us think of our ears when we think of hearing, but you're saying that the ear is also responsible for our ability to navigate space or our balance, essentially?
Right, for our orientation. And, located right next to the vestibular system is the auditory system. So that's going to be key as well when we talk about some of these diseases, because they're also associated sometimes with hearing loss.
Oh, makes sense.
And so we've got these semicircular canals again. And at the base of those canals is another structure called the ampulla. And the ampulla contains a jelly-like substance called cupula. And this inside there, this cupula is attached to hairs, little hair cells. And so when there's motion that goes on, fluid in these semicircular canals moves that cupula, which moves the hair, and then the direction that the hair moves, allows us to detect that motion is going on.
Okay, so we have these little hairs in our ears, and then you said there's kind of like this jelly-like liquid on it, and the way that the hairs move and the jelly kind of is interacting is how our body essentially determines our orientation.
Right.
Okay.
And so that is more of movement, like turning and so forth. There's also other organs called otoliths, and these otoliths are near the semicircular canals, and they're responsible for detecting linear motion. So if I'm moving in a straight line and not changing in the acceleration and stuff like that. And the vertical is what's responsible for detecting forward and backward motion. And another, the saccule is related to up and down motion.
Interesting. So, can I just say that all these things sound like they belong in a fantasy universe? So, otoliths, etecules, saccules, like this seems like I'm going to, I don't know, Narnia or something.
The inner
the
ear
quantum realm.
The quantum realm.
Yes,
Aren't you keeping up with the Marvel movies?
There
Ben?
you go.
I'm actually not, but I know what you're talking about. That was a better reference.
So to help Ben better understand these things, I think we're going to post some pictures on our website that'll help give a little bit of visualization, to these structures.
Yeah, that would be great because you have some of them typed out here for us, and it is a lot easier to understand if there's a visual reference,
right,
for sure.
Right. And so now you had mentioned, again, that I've already referred to these hair cells. And these are the cells that are located both in the semicircular ducts and those otolith organs. So the hair cells in your ear are really important. And they contain a unique set of sensory epithelial cells or lining cells. And they function to convert the acceleration and the direction into an electronic signal that's then processed by your central vestibular system.
Okay.
So there's a brain part to this as well.
Gotcha. So we talked a little bit about, I'm going to ask a very stupid question, Mike, so I apologize. I know you're not used to this from me. So
I'd expect nothing else.
So is this different than earwax, like this cupula stuff you're talking about?
This is much different from earwax.
Okay.
So earwax is more external to everything that's going on in your ear, and this is on the other side of your tympanic membrane or eardrum.
Gotcha. So this is inner ear stuff you're talking about. Got it.
Right.
Okay.
All right. A little bit more anatomy, then we're going to move on. Okay.
I love anatomy.
Okay. So here we go. Then you will love all of this. And so those cells, those epithelium of the semicircular ducts are known as the cristia ampullaris and is located within the ampulla at the base of the canals. And, the tissue within the urticle and the saccule, possesses these processes, these hair cells called stereocilia. Okay. There's a number of those, and they go from rows that start short and get progressively longer in length until they reach, an area where they can sense the excitation and inhibition of the movement. And when the head movement bends the cilia towards this structure called the kinocilium, you get a excitatory potential. And when it bends away, you get an inhibitory potential. So not only do you detect the start of movement, but stop. And this all helps keep you locked into your environment and not just feel like you're in constant motion.
So I love anatomy, Mike, but you got my head spinning. It's too much.
All right. Well, essentially, here's the thing. What you need to know is that when your head moves or changes directions, it causes movement in the fluids, in the vestibular canals and the otoliths. And when that fluid moves, it stimulates those hair cells, in the brain.
Okay, got it.
All right. Well, you're processing that. Let's take a moment and go on and hear from Mark in the Healthy Minute.
Today's Healthy Minute is keep your bones healthy. Osteoporosis is the weakening of our bones as we age. All women over the age of 65, women who are over the age of 50 and have a family history of osteoporosis, and all men over the age of 70 should get a simple, non-invasive DEXA scan to determine the strength of their bones. Weight-bearing exercise, adequate calcium and vitamin D intake, and medications can help make your bones stronger. Investing in osteoporosis prevention is an investment in your long-term health and well-being. By adopting a bone-friendly lifestyle, staying active, and seeking timely medical advice will reduce the risk of fractures later in life. That was the Healthy Minute, brought to you by The Winery at Young Farms in Mecosta, Michigan. Please visit www.thewineryatyoungfarms.com for more information. Now, back to the Health Deli.
Boom, chicka, boom, healthy, 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 healthy. All right. Thank you, Mark. I appreciate that. And let's spin back into our topic of vertigo.
We spinning.
Yes, we are. So when everything's normal in this vestibular system, that you've got in your ear, the body does not send signals when the body is not in motion. Okay. And vertigo occurs when there's a problem in the vestibular system, or the nerve between the inner ear and the brain, or the brain itself. So you can have vertigo at each of those areas.
Okay, so you essentially, your body turns off this system when it doesn't need it anymore.
It's like it's not firing at that point in time. So it's like if you're in a quiet room, you don't hear anything, but you could if there was sound.
Gotcha.
If that makes sense.
Okay.
And so there's two different types of broad classifications of vertigo. There's peripheral vertigo, which is a problem of the inner ear or the nerve leading to the brain. And then there's central vertigo, which is a problem of the brain, and usually part of the brain stem. Okay. Approximately 80% of all vertigo is peripheral in nature. And so we're going to focus a little bit more on that.
Okay. I mean, I guess that makes sense, right? Because you said it's mainly a bunch of these just little tiny hairs, right? So I'm guessing that's more fragile than our spinal column or, that kind of thing.
I don't know that it's necessarily more fragile, but there's a lot of things that can influence those hairs, and they can kill off those hairs, the epithelium, or damage things.
Gotcha.
Hopefully you're not having a lot of trauma to your nerves, because that's usually associated with more significant trauma, or if you have damage to your brain, that can be associated with head trauma. So those are quite severe in and of themselves.
Right. You probably have something else going on than just vertigo,
right,
if that was what's going on. Okay, makes sense.
So one of the most common causes of vertigo is something called benign paroxysmal positional vertigo, or BPPV. And paroxysmal essentially just means sudden or violent increase. Okay. And this type of vertigo, this BPPV, causes about 80% of vertigo cases.
Okay.
This type of vertigo typically affects older individuals. And according to a study published in the Journal of Neurology, Neurosurgery, and Psychiatry, the lifetime prevalence of an individual experiencing this type of vertigo is about 3.2% in women, 1.6% in men, and roughly 2.4 to about 10% overall. So it's not insignificant numbers.
So about 2.5 to 10% of all people will experience this kind of vertigo?
Correct. Correct. Okay. And the 1-year prevalence among individuals who have already experienced an episode of vertigo was about 1.6%. And the 1-year incidence of new cases for those that have not experienced is about 0.6%. So, it's not something that affects a lot of people, but once you get it, you're probably going to keep, having some episodes.
Right. Okay. Makes sense.
And so what causes this, type of vertigo? I would assume that would have been your next question. Are you paying attention here?
I mean, I was thinking about it, but I was too busy thinking about...
Your head's spinning and stuff like that. And yeah, I get it. And so this type of vertigo is actually caused by displacement of these little crystals or otoliths or calcium debris in the semicircular canals. And these are also called onoconia or canaliths. And when these little crystals dislodge, they kind of roll through the semicircular canals and the saccules, and they hit those copula that have the hair cells in them. And so they start knocking those hair cells around, so you start to think you're moving when you're really not moving.
Interesting. So it's literally, there's these little crystals that are physically bumping into the hairs.
Correct.
Wow.
And then this is going to be important because, when we talk to treatment, but initially, why these crystals dislodge and start floating around is really not understood. But there's a lot of theories, maybe if you have a lot of repetitive head motion, like looking down at a keyboard, up at a computer monitor, you get head trauma. All these things could potentially dislodge some of these crystals. Okay. Additionally, they thought that there might be some inflammation that causes dislodging, due to viral infections, nerve damage, medications, or again, just rapid head movements.
Okay. And so we know that, so us as infectious disease people, we know that some antibiotics can cause these kinds of problems with our ears. Is that the same kind of mechanism?
Probably not the exact same type of mechanism, because a lot of the antibiotics don't have anything to do with dislodging crystals, but they affect maybe more those hair cells, that epithelium, and might damage those directly.
Gotcha.
And so they have a different type of effect.
Okay. But it all kind of comes down to these little hairs and them getting bumped into, damaged, something like that.
Right.
Okay.
And so onto the symptoms, of this, so the symptoms of vertigo, or this benign paroxysmal positional vertigo, include vertigo,
Makes sense.
loss of balance and falling, nausea, vomiting, this crazy thing called nystagmus that I'll talk a little bit about. Key thing here, though, when patients have this BPPV, there's no loss of hearing or ringing in the ears. Okay, so keep that in mind. But this nystagmus, this is key because, this is a rapid eye movement, and so you'll be looking straight forward, but your eyes will be jumping. And that's key because your brain then also senses that is creating motion around you when maybe there is no motion. And so if you look at somebody's eyes, you can kind of get a little bit freaked out.
Interesting.
And see that nystagmus.
And so that's entirely involuntary.
Involuntary, right. And, that's why we'll talk about one of the ways that you can help deal with some of the symptoms is to retrain your brain. And they have you do these things where you stare at something and then you keep your eyes at that thing at that point and move your head in all different directions. So you kind of train yourself that even though there's motion, yeah, you got it, Andrew. Keep the head going over there. So you can retrain it, to do that. Now, the good thing about BPPV is that usually symptoms resolve relatively quickly, and symptoms resolve when those crystals clear the canals. And typically this occurs on its own.
Okay.
But there's also maneuvers that can be done and physical therapy that can be done, to help with, this as well. But before I talk about treatment, I got to talk about diagnostics and how we diagnose somebody with this. And it's tough because there's not like a lab test that you do to diagnose somebody with this.
You mean I can't just like poke a needle in your ear and then pull out some crystals or something like that?
No.
It doesn't work like that?
No, it does not work like that. However, there are a list of criteria to have somebody be diagnosed with BPPV. And these include recurrent attacks of positional vertigo, meaning if you're standing up or turning or whatever.
Okay.
The duration of attacks are typically short, less than a minute. If you have that positional nystagmus, so the moving of the eyes, and here's the key thing, not attributable to something else. So essentially, this is kind of a diagnosis of exclusion.
Okay.
We can't find anything else.
Gotcha. And so just to prove that I do listen when you talk, Mike, this doesn't really sound like the symptoms that you were experiencing. So I'm going to guess that you don't have BPPV?
This is correct. And I'll kind of get into that in a moment here. Well, let's just put a bow on this BPPV and then talk about what I got going on.
Okay.
And so for this BPPV, like I mentioned, it's these crystals, and the symptoms go away when those crystals clear. And so the goal becomes to move those crystals from the semicircular canals back into other areas of the ear and the vestibule that don't have the hair cells. And so they're kind of hidden away, then they get reabsorbed. And one of the ways that we do that is through vestibular rehabilitation therapy, or VRT.
Okay.
And VRT is a form of physical therapy, like you mentioned, that takes advantage, really of your body's ability to heal itself. And the most common VRT that we use is something called the ep9 maneuver. And we've got this posted on our website so individuals can kind of see the process and see the imaging. But this is something that can be done by a provider or by individuals. And essentially what the ep9 maneuver does is it has your head tilt from side to side, go to different positions to force those crystals out of these semicircular canals. And since you don't know which of the canals it's in, you have to go in all these different planes and areas to move the crystals along.
Okay. And so how successful is this then? If you did have BPPV and you were having an episode, how likely would this be to actually help?
It's been shown that this is about 80% effective, so it's really highly effective, and this is the most effective treatment for patients with BPPV. It's even more effective than medications.
That's better than a lot of medications for a lot of disease states.
Yeah, no, I hear you. So that's highly effective. So if you have been diagnosed with benign paroxysmal positional vertigo, learning how to do something like the ep9 maneuver is going to be key to your dealing with this condition.
Yeah, it seems like that would improve your quality of life a lot if you could do this and hopefully resolve all this bad stuff that's happening.
Most definitely. And then once you can clear those crystals, you really don't need the medication because your symptoms go away. So using things to control nausea and other things, might provide some relief, but not as important for this type of vertigo.
Yeah, makes sense. Address the underlying cause, and that'll hopefully cause the other things to get better on their own.
Exactly. Treat the cause, not the symptom. And so now we'll move on to me.
How you doing, Mike?
I'm doing better today.
That's good to hear.
So initially they thought I had benign paroxysmal positional vertigo, and they were doing Epley maneuvers and all this stuff on me. And I had my one episode that we talked about, and then I went quite a long period of time without having any additional episodes.
Yeah, because you said the first one was 6 months ago. This last one was a month and a half ago.
My first episode was probably about 6 years ago.
Oh, okay.
And then in between there, maybe about 3 years ago, I started noticing some weird things in my hearing.
Okay.
First off, everybody started to sound like a robot.
I'm
really
a robot?
kind of like, well, if you were, you'd be a lot cooler than you are now.
Fair.
But they sounded kind of like really tinny and robotic. And I also noted that when I was laying in bed, putting my daughter to bed, she's got a white noisemaker. If I'd sit upright, I could hear it. If I'd cover one ear, I couldn't hear it. And if I'd roll to the other side, I could hear it again. So I started noticing some changes in my hearing, and that's what actually made me seek care. Yeah. And after I did that and had some audiologic exams, I started noticing some decrease in my hearing. And when they started asking me about other things, I mentioned my history of vertigo. And they said, oh my gosh, I bet you might have this thing called Meniere's disease. And I'm like, whoa, that sounds crazy.
Yeah.
And so that's started my path down this diagnosis of Meniere's disease.
Okay. And so I'm going to take a stab and say that Meniere's disease is different than BPPV. You don't have those crystals floating around, or there's still crystals.
No, you do not.
Okay.
No crystals with Meniere's disease. Meniere's disease is maybe the second most common cause of vertigo, and it affects maybe about 50 to 200,000 50 to 200,000 per. Well, here we go. This is causing my statistical mind not to work. It affects maybe 50 to 200 per 100,000 adults. And it's most commonly diagnosed at the ages of 40 to 60 years of age. And the cause of Meniere's disease is not really understood, but it has been associated with changes in the inner ear fluid volume. And this fluid's called endolymph, and we all have it in our ears, and it just kind of bathes everything. And when individuals with Meniere's disease, they have an increase in the amount of this endolymph. And because of the increase, there's increased pressure in that inner ear, which then leads to vertigo symptoms, hearing loss, and a feeling of fullness in the ears. But again, no crystals involved.
Okay. And so do we know where all this endolymph comes from? Is it just that your body produces too much? It can't get rid of it fast enough?
So that's, again, $1 million question. For Meniere's disease, it's all a lot of hypotheses, at this point in time. And if you look at the data around Meniere's disease, it's not great because the disease itself is not truly that common. But, we think that the body produces the, endolymph at high concentrations. And then to treat Meniere's disease, they try to decrease the production or decrease the pressure. So for me, one of the things that I have to do is be on a very low salt diet.
Okay.
I can only have about 1.5 to 2 grams of salt a day.
That's not a lot of salt.
That is not a lot of salt at all. And I use an app from the Dash Diet, which helps me track a lot of things. And it's a free app that you can track not only calories and everything, but also allows me to track sodium. And the thought being that if you have less sodium in your body, you're going to have less fluid accumulating, in your inner ear. And also a thing that they put me on are diuretics. So again, helping with some of the pressure and the fluid buildup.
Yeah, and diuretics are just things that make you hopefully urinate out more fluid. Yeah, pee is another good word for it. So one thing I did want to touch on, Mike, before moving forward, is that this is something that's kind of unfortunate about very rare diseases is we just don't have a lot of information on them. So we don't really know how they work. We don't have great treatments. And that's just because it's so hard to study. There's just not that many people that we can look at.
Right. And another thing with these types of diseases, like I talked about with BPPV, is it's a diagnosis of exclusion. And so getting a firm diagnosis for some of these patients is quite hard because you roll through everything else first.
Right.
But Meniere's disease, to make that diagnosis, an individual has to have 2 or more spontaneous attacks of vertigo, each lasting 20 minutes to 12 hours. So unlike BPPV, which was minutes, we're talking minutes to hours.
12 hours of this sounds miserable.
Yes, it is. And then also along with the vertigo, there needs to be a documented decrease in hearing function. And there should also be accompanying some changes in other items related to the ear. So that feeling of fullness, that hearing loss, or tinnitus or tinnitus, which is kind of the ringing in the ears. So that's quite vague.
Yeah.
But that's how you make that diagnosis of Meniere's disease.
Yeah. Because I mean, other things can cause tinnitus and stuff, right? Like other things can cause dizziness. So I guess that comes back to what you're saying. It's really hard to diagnose this.
Right. And, the attacks for Meniere's disease, there's really nothing that's, been said, this triggers your attack. And they are totally random. Like I mentioned, I can just be sitting at a computer. I could just be sitting here talking, and then all of a sudden, boom, I'm having an attack. And usually people with Meniere's disease have about 6 to 11 attacks per year. Sometimes periods will last between from months to years, but it all just depends on where you're at, because this is kind of a progressive disease as you lose the function in your vestibular system. And when you have big changes, then you're usually more associated with more severe episodes.
Okay.
But again, the key thing here, treatment is tough because there's no therapy like Epley maneuver or something like that you can do for these patients.
Right. And so you mentioned some diet stuff and some medications, I guess.
Right. And so, the diet stuff we talked about, some of the medications that we can use, usually they do things to help manage or kind of slow down the processing of some of these neurological signals. So using things like benzodiazepines, Valium, Ativan. I carry around a little pill vial with me now that has Valium and a medication called Zofran in it. The Valium is to help maybe with my symptoms with the spinning. The Zofran is for the nausea and the vomiting. And if I feel an episode coming on, sometimes I can get the medications quick enough and treat it so it goes away.
Okay.
Sometimes the episode is just fast and furious. And there's been times when I've taken my medication and less than a minute later, I'm just totally incapacitated.
Yeah. And so that's really tough, because we talked before about how with the BPPV, it's nice to address the problem, right? Let's solve the issue that's causing all these symptoms. But in this case, we don't have as much reliable things that can do.
And all of these things that they're able to or suggest doing, like the low salt diet, that's not going to be beneficial for everybody. And so that they go in knowing that. There's also things that they've done. They've injected steroids, things to make things, the inflammation go down. They've injected those into my ear to hopefully preserve some of my hearing function. I've had to take oral steroids, again, hopefully preserving some of my hearing function. It's not intended at all to do anything for the vertigo, but that's trying to preserve my hearing. Now, most people that have Meniere's disease typically have it just affect one ear.
Okay.
I'm the lucky 10 to 20% that's got it in both ears. And
wow.
So this makes things even more complicated, because if you only had one ear involved, you could do things to kind of cut off the vestibular system in that ear from the rest of your body. So you don't get those signals, and it can be fairly effective at reducing the vertigo signs and symptoms. But if you have both ears involved or bilateral involvement, doing something like that can actually make things worse.
Gotcha. Interesting. Yeah. And this is so important, because you mentioned this is a progressive disease. And so it probably is going to continue to get worse over time.
Yeah. And, the unfortunate thing is you talk to people, and some people have it so bad they have to go on disability. Some people have to get their driver's license taken away. In fact, so my most recent episode, severe episode, I was laying in bed, and all of a sudden I started to feel kind of weird. and I, asked my wife to bring me some medication. I took the medication, and then less than a minute later, I ended up in the bathroom, and I was in the bathroom probably for about an hour and a half. It really wasn't coherent. Again, this is the episode where all I could get out was hospital ambulance, and she came in just, she saw me there. And at that point in time, I'd been throwing up for about an hour. And so I had actually torn my esophagus and I had the blood going into my stomach and was digesting and was, vomiting what we call coffee ground emesis. And so she was freaked out because I looked kind of like the Exorcist in there just calling for an ambulance. And I remember the medics coming, having to drag me out of my bathroom, take me to the hospital. I go into the emergency department. All I can do is just keep my eyes closed because anytime I open my eyes, everything is just shaking, moving, jumping. And it took quite a while for them to, get me medication so I could stop that feeling. And I was actually in the hospital for about 3 days, for that episode.
Yeah, that's absolutely terrifying. Like, I'm not going to lie that.
Yeah.
I feel so bad.
You're quite helpless during that time because, again, there's nothing you can do to console yourself. There's nothing you can do to make the symptoms go away. You just close your eyes, close your eyes, close your eyes. Right now what we're doing with my doctor is trying to figure out what to do next. Because since that big episode, fortunately, I have not had any big episodes that have landed me in the hospital since then, but I have had episodes where it's knocked me out and put me in bed for 9 hours or 12 hours. And all you can do is just lay there and keep your eyes closed. Even if you're not sleeping, my wife always comes in and asks me if I, thinks I'm sleeping. I'm like, no, I can't. Because if I open my eyes, she sees my eyes doing that nystagmus thing.
Oh, okay.
And it, and so we don't know what to do. I guess the next thing for me is I've been trying the low salt diet, and I have been very adherent to this. Had the injections, had the steroids, and really not a lot of improvement.
Okay.
I think we're looking next at doing some surgical interventions to create a little sac in my ears to relieve some of the pressure. But again, that's no guarantee.
Yeah.
And there's risks that if you have those surgical interventions, it can produce permanent hearing loss because the cochlea, which is responsible for your hearing, and the vestibular system are right there together in a teeny tiny little area.
Yeah.
And so it's tough to get in there and do those things.
And high risk for, accidentally cutting something that you shouldn't because it's also small and close.
Yeah. And so, again, this is kind of the journey that I'm going through, experiencing the vertigo, going through this low salt, which could be an episode in and of itself, like all the places you have hidden salt, because as health professionals, we a lot of time have people come in and go, you got to eat better and exercise more.
Yep.
And we just say it like, it's just do it.
It's a lot easier said than done.
Oh, it is. Because if you start looking at what's in salt, bread's got a lot of salt, flour tortilla wraps, Chinese food, Mexican food, a lot of, takeout food, pizza off the table.
Yep.
I got to be very careful. Pepperoni, salami, cheeses, all these things are pretty high in salt. And there's this fine balance between, because I can't totally cut salt out because your body needs salt. And so I walk this line with getting too much salt, not getting enough salt. And that's where I'm at all the time. And, just talking about some of the strategies and how to do that, might be a good episode in the future for folks as I, move along this journey.
Yeah. I mean, I 100% agree with you. That's a complete change in your life if you're going to go to a low salt diet, because a lot of people just eat salt all the time.
Well, and it is, and you don't think about it. So, again, a lot of lifestyle changes. But, so I made jokes about this for years in terms of I have high cholesterol since I was younger than you've been. And so they always, put me on a statin and they told me to eat, healthier food. And you just go, you just kind of laugh and you go on and do your thing because you don't feel it.
Right.
Okay. Until you maybe have a heart attack or something like that. This you feel. Okay. This is real. And my doctor described it as, consider yourself a salt diabetic. At this point in time, that if your salt gets out of control, you're probably going to feel it. You're going to notice changes in your hearing, increased risk for these episodes. And because the vertigo itself, when I first described my condition to my doctor, and I said, I felt it coming on, got the medications, and then a minute later I was throwing up, incoherent. He said, the fact that you said it took a minute saved me from taking your driver's license. Because otherwise, if it just came on with from nothing to 100 miles an hour, he said that's like a seizure,
right?
And you can't be driving,
right?
But at least if I have a minute's notice, I'm able to pull off to the side of the road, hopefully get safe, maybe call a family member, 911 or something else. I'm also working on getting a medical alert bracelet.
Okay.
Because if I end up, in a ditch, throwing up incoherent, I want people to know what's going on and not think, substance abuse or a drunk or something like that.
Right. Yeah. And someone can come and help you. Oh, gosh, that's wild. When you're talking about salt restriction and those kinds of things, Mike, it made me think, do we have any information on whether having a chronic high salt diet could cause something like this? Do we know if that's related at all?
We don't know much of anything. Again, what the predisposing factors, what some of the triggers are. So trust me, as I go through this journey, I'll continue to share what I find. Also talk maybe a little bit more, about vertigo, in and of itself, because it occurs to a lot of people and it's quite debilitating. The sad thing for me is I'm looking over there at the meat counter, where Mark usually is. All those meats in there are now off my dinner table. All them, wonderful deli meats.
Yeah.
And so, with that, let's get out of here before I start drooling on that meat case. I'll go find myself a salad and, put some low salt vinaigrette on it, and we'll get some lunch.
All right. Sounds good. I'll be right with you.
All right. So until the next time, everybody, stay healthy.
Thanks for stopping by the Health Deli to sample some of our wares. We're open 24/7 on Facebook and Twitter at The Health Deli, or visit thehealthdeli.com to send us a question or find any of our locations. Please come again. We will be regularly stocking the shelves with fresh content and new wellness specials. As always, we want to give a special thank you to Andrew Tingley and the crew at Ferris State University's Television and Digital Media Production Program. Until next time, so long from the Health Deli, where the topics are tasty, the takes are fresh, and the discussion is free.